Hello everyone, I am Shweta welcoming you to the Medical and Pharmacy Crash Course Division in the Knowledge Club online. At previous episode, we learned about types of angina, classification of anti-anginal drugs with their general mechanism of actions, detailed pharmacological study of organic nitrate drugs, right? The link of this episode you will get at description box of this video. Today, I will discuss on rest of the part of antianginal drugs, means beta blocking agents, calcium channel blocking agents, and some new type of drugs using for anti-anginal treatment. No more about the anti-anginal drugs in this episode. Stay tuned up to the end, don't skip the lecture. If you skip, you can miss a valuable points in between lecture. So I am going to start today's episode. So let's start. Now come to the point, the second type of anti-anginal drug, that is beta adrenoceptor antagonist or beta blocking agents or drugs. Although they are not vasodilators, with the exception of carvedilol and nebivolol. Beta blocking drugs are extremely useful in the management of effort angina and are considered first-line drugs in chronic effort angina. The beneficial effects of beta blocking agents are related to their hemodynamic effects: decreased heart rate, blood pressure and contractility, which decrease myocardial oxygen requirement at rest and during exercise. Lower heart rate is also associated with an increase in diastolic perfusion time that may increase coronary perfusion. However, reduction of heart rate and blood pressure and consequently decreased myocardial oxygen consumption appear to be the most important mechanisms for relief of angina and improved exercise tolerance. Beta blockers may also be valuable in treating silent or ambulatory ischemia because this condition causes no pain. It is usually detected by the appearance of typical electrocardiographic signs of ischemia. The total amount of ischemic time per day is reduced by long-term therapy with a beta blocker. Beta blocking agents decrease mortality of patients with heart failure or recent myocardial infarction and improve survival and prevent stroke in patients with hypertension. Beta adrenoceptor antagonists decrease heart rate, blood pressure and contractility, resulting in decreased myocardial oxygen requirement. Combined therapy with nitrates is often preferred in the treatment of angina pectoris because of the decreased adverse effects of both agents. Beta adrenoceptor antagonists are contraindicated in the presence of bradycardia, AV block and asthma. Undesirable effects of beta blocking agents in angina include an increase in end-diastolic volume and increase in ejection time, both of which tend to increase myocardial oxygen requirement. Third type of antianginal drug is the calcium channel blocking agents. It has been known since the late 18th centuries that transmembrane calcium influx is necessary for the contraction of smooth and cardiac muscle. The discovery of calcium channel in cardiac muscle was followed by the finding of several different types of calcium channels in different tissues. What is the mechanism of action or pharmacodynamics? The voltage-gated L type is the dominant type of calcium channel in cardiac and smooth muscle and is known to contain several drug receptors. It consists of alpha-1, the larger pore-forming subunit, alpha-2, beta, gamma, delta subunits. 4 variants, alpha-1 subunits have been recognized. nifedipine and other dihydropyridines have been demonstrated to bind to one site on the alpha-1 subunit, whereas verapamil and diltiazem appear to bind to close related but not identical receptor in another region of the same subunit. Binding of a drug to the verapamil or diltiazem receptors allosterically affects dihydropyridine binding. These receptors regions are stereoselective since marked differences in both stereoisomer binding affinity and pharmacologic potency are observed for enantiomers of verapamil, diltiazem and optically active nifedipine congeners. The drugs act from the inner side of the membrane and bind more effectively to open channels and inactivated channels. Binding of the drug reduces the frequency of opening in response to depolarization. The result is a marked decrease in transmembrane calcium current, which is smooth muscle results in long-lasting relaxation, and in cardiac muscle results in reduction in contractility throughout the heart, and decreases in sinus node pacemaker rate and atrioventricular node conduction velocity. Although some neuronal cells harbor L-type calcium channels, their sensitivity to these drugs is lower because the channels in these cells spend less time in the open and inactivated state. Calcium channel blocking agents produce a blockage of L-type, means slow calcium channels, which decreases contractile force and oxygen requirements. Agents cause coronary vasodilation and relief of spasm. They also dilate peripheral vasculature and decrease cardiac afterload. Pharmacokinetic properties. Calcium channel blocking agents can be administered orally. When administered intravenously, they are effective within minutes. These drugs are useful for both variant and chronic stable angina and are also used in instances where nitrates are inactive or ineffective or when beta-adrenoceptor antagonists are contraindicated. Serum lipids are not increases. These drugs produce hypotension and edema is a common adverse effect. Some selected drugs. Number 1, verapamil. Verapamil produces slowed conduction through the AV node, predominant effect. This may be an unwanted effect in some situations, especially in the treatment of hypertension. Verapamil may produce AV block when used in combination with beta-adrenoceptor antagonist. The toxic effects of verapamil include myocardial depression, cardiac failure, and edema. Verapamil also has peripheral vasodilating effects that can reduce afterload and blood pressure. The peripheral effects of verapamil can produce headache, reflex tachycardia, and fluid retention. Number 2 type of drug, nifedipine, istradipine, nisoldipine, and nicardipine. These dihydropyridine calcium channel blockers have predominant actions in the peripheral vasculature. They decrease afterload and to a lesser extent preload and lower blood pressure. These drugs have significantly less direct effect on the heart than verapamil. Number 3, diltiazem. Diltiazem, a benzothiazepine, is intermediate in properties between verapamil and the dihydropyridines. Diltiazem is used to treat variant angina, either naturally occurring or drug-induced and stable angina. Number 4, dipyridamole. Dipyridamole is a non-nitrate coronary vasodilator that interferes with uptake of the vasodilator adenosine. It potentiates the effect of PGI2 and dilates resistance vessels and inhibits platelet aggregation. Dipyridamole may be used for prophylaxis of angina pectoris, but the efficacy of these drugs is not proved. Dipyridamole produces adverse effects that include the worsening of angina, dizziness, and headache. Toxicity of the calcium channel blocking agent. The most important toxic effects reported for calcium channel blockers are direct extensions of their therapeutic action. Excessive inhibition of calcium influx can cause serious cardiac depression, including bradycardia, atrioventricular block, cardiac arrest, and at last heart failure. These effects have been rare in clinical use. Retrospective case control studies reported that immediate acting nifedipine increases the risk of myocardial infarction in patients with hypertension. Slow release and long acting dihydropyridine calcium channel blockers are usually well tolerated. However, dihydropyridines compared with angiotensin converting enzymes ACE inhibitors have been reported to increase the risk of adverse cardiac events in patients with hypertension with or without diabetes. These results suggest that relatively short-acting calcium channel blockers such as prompt-release nifedipine have the potential to enhance the risk of adverse cardiac events and should be avoided. Now, I will discuss about some newer anti-anginal drugs. Because of the high prevalence of angina, new drugs are actively sought for its treatment. Some of the drugs or drug groups currently under investigation. Number 1. Ranolazine appears to act by reducing a lead sodium current INA that facilitates calcium entry via the sodium calcium exchanger. The reduction in intracellular calcium concentration that results from ranolazine reduces diastolic tension, cardiac contractility and work. Ranolazine is approved for use in angina. Several studies demonstrate its effectiveness in stable angina, but it does not reduce the incidence of death in acute coronary syndromes. Ranolazine prolongs the QT intervals in patients with coronary artery disease but shortens it in patients with long QT syndrome LQT3. It has not been associated with torsades, D points, arrhythmia, and may inhibit the metabolism of digoxin and simvastatin. Number 2 type of drug is trimetazidine. Certain metabolic modulators are known as PFOS inhibitor because they partially inhibit the fatty acid oxidation pathway in myocardium. Because metabolism shifts to oxidation of fatty acids in ischemic myocardium, the oxygen requirement per unit of ATP produced increases. Partial inhibition of the enzyme required for fatty acid oxidation, long-chain 3-ketoacylthiolase ALC3-KAT appears to improve the metabolic status of ischemic tissue. Ranolazine was initially assigned to this group of agents, but it lacks this action at clinically relevant concentrations. Number 3 type of drugs is the parhexylene. Was found to benefit some patients with angina decades ago but was abandoned because of the report of hepatotoxicity and peripheral neuropathy. However, pharmacokinetic studies suggested that toxicity was due to variable clearance of a drug with extremely high plasma concentrations in patients. So-called bradycardiac drugs relatively selective if sodium channel blockers, that is, the ivabradine, reduce cardiac rate by inhibiting the hyperpolarization activated sodium channel in the sinoatrial node. No other significant hemodynamic effects have been reported. Ivabradine appears to reduce anginal attacks with an efficacy similar to that of calcium channel blocker and beta blocker. And last type of agent, that is ALLOpurinol, represents another type of metabolic modifiers. ALLOpurinol inhibits xanthine oxidase an enzyme that contributes to oxidative stress and endothelial dysfunction in addition to reducing uric acid synthesis. Its mechanism of action in gut. Studies suggest that high-dose allopurinol, that means the 600 mg per day, prolongs exercise time in patients with atherosclerotic angina. So, we completed about the study of antianginal drug, vasodilator, nitrates, calcium channel blocker, beta blocker in pharmacological relevance. I think it's very easy to understand right now. Revise the all episodes on heart thoroughly. I made each step by step accordingly. Here the all previous episodes list on heart anatomy and physiology. You will get all links at discussion part of this video, or you can visit our channel. This is the first chapter of Pharmacology of Heart series. Next day, I will come with another cardiac pharmacology chapter, antiarrhythmic agents or drugs. Before ending today's episode, if you like this video, please like, share and comment freely. Don't forget to subscribe our channel. If you already subscribed, then thanks a lot. And after subscribing our channel, please click on the bell button for getting the regular update. I am coming with another episodes very shortly. Till then, goodbye.